Dr. Tom Meade. I'm an orthopedic surgeon, and I limit my practice to knees. Why the heck am I here talking about the opioid epidemic? And I'll answer that in a second, but I want to thank the Parkland School District and everybody from Parkland that helped support this and put it on today. And a shout out to Rich Cisnek, the superintendent, who is really supportive of this topic and having it here at Parkland High School. And I want to thank Coordinated Health also for supporting that. So in the last 2 years, I've learned an awful lot about the opioid epidemic. And what I found is there's 5 P's of the root cause of the opioid epidemic, and we are one of those P's, the physicians, in addition to the payers, patients, pharmaceutical industry, and the politicians. And if you're part of the problem, you better be part of the solution. So 2 years ago, I had very little knowledge or interest in the opioid crisis. What I was interested in was the total joint problem and the scope of that problem in this country. At that point, there was over 1 million total joints done in this country, and it's looking to explode in the next 15 years, up to 3.5 million, an increase of 700%. Historically, this problem is managed poorly from both a financial standpoint and a pain standpoint. And my concern is we can't afford this the way we're doing it now. Traditional hospital beds cost too much. There's too many medical errors. Medical errors are the 3rd leading cause of death in this country. That's hard to believe. Medical errors are the 3rd leading cause of death, right behind cardiology deaths and cancer deaths. And the traditional way that we do joint replacements is somewhat antiquated. You know, you're worked up for a month or 2 ahead of time. You get your blanket and your iPhone and your books, and you go to the hospital like you're camping out for a couple days, and you have surgery. You expect a lot of pain because that's how it was done. Your neighbor said this is a terrible, painful operation. You're there for an average of 3 days across the country, and then you often go to rehab. There has to be a better way to do this. And you can't just say, well, let's send the patient home without a comprehensive program. So we developed this comprehensive program with SwiftPath where you have to educate patients, you have to educate the whole team. And one of the key aspects of doing this to select the proper patient, select the proper protocols, pick the right location, the right length of stay. Some people can go home the same day. A significant majority can go home the same day. And if you're in the hospital, you don't have to be there 3 days. So I became an educator for SwiftPath, and my role was to really develop an interest in this non-narcotic approach to surgery. It's called a multimodal approach. And the foundation are the top 3 medications, believe it or not. Acetaminophen, which is Tylenol, non-steroidal group of medicines, the Advils, the Motrins, the Celebrexes, gabapentinoids, which are the Neurontins, and the Lyricas. So this combination of medications, which is a whole different educational experience, along with different techniques, were really the foundation of getting rid of most of the narcotics or just using them for breakthrough pain. There's nothing better than narcotics to have acute pain, but frankly, as the primary treatment, it is absolutely not necessary, what we've used for 3 decades. Drug overdoses are now the leading cause of accidental death in the United States, surpassing auto accidents. So the prognosis is guarded until we stop prescribing opioids in far excess of clinical needs. And even in the last 2 years, when we sort of concentrated on total joints, we do a lot of minor procedures like arthroscopies. And all these patients, we'll put them on anti-inflammatories and Tylenol, and basically that's all they need. But yet I look, and from our office, they still have a prescription for 30 or 40 Vicodin or Percocet or Oxycontin. I go, what are we doing? It's just this habit that is so hard to stop. And even if these patients don't use them or abuse them, they end up in the medical cabinet. We're going to talk about diversion. So we're part of that problem because we follow the path of least resistance, just to to prescribe them for the worst case scenario. So with that, that's our small contribution to this opioid epidemic, where we're starting to avoid this in a hospital setting. There's so much more work to be done. I want to introduce Pauline Vargo. She's the owner and manager of the Medicap Pharmacy, a community pharmacy. She works with Lehigh Valley School, administers, and has been a champion of the use of distribution of naloxone, and she's going to talk about that in addition to some other topics.
So I'm going to talk to you a little bit today about the use of naloxone in our communities and our schools. As he's mentioned, there is a huge problem with opioid deaths occurring in our communities. The CDC has declared that the U.S. is in the midst of an epidemic from these drug overdoses, and it does outnumber motor vehicle accidents, and prescription opioid deaths actually outnumbers the deaths from heroin and cocaine combined. So some of the commonly prescribed opioids are oxycodone or OxyContin, morphine, codeine, Vicodin or hydrocodone, and fentanyl. So only use prescription medications as prescribed. Don't take more, and don't share or take someone else's prescription medications. So what do you do if your child is using drugs? So that's a big question to ask, but it's something that just needs to be said. We need to keep an open communication with our children, and we need to talk to them about drugs frequently. But if you happen to know that they definitely are using, you want to remain calm, because how you react can definitely have an impact in how their recovery is going to be. You need to have an open mind about recovery, and you need also not to blame yourself, and know that you're not alone, which I know Donna is going to be speaking upcoming, and she'll talk more about this. Naloxone is a life-saving medication. What it does is, if someone takes opioids, naloxone's sole purpose is to knock opioids off of the receptors that it binds to in the brain that cause respiratory depression. So typically, naloxone will reverse an overdose within 2 to 5 minutes after administration. And it's effective for 60 to 90 minutes after administering, which it's important to get someone after there is an overdose, to get them into emergency care, call an ambulance, get them to the hospital as soon as possible. Naloxone has no potential for abuse and will not harm someone if it's given to them in a case where they're inadvertently not overdosing, but maybe something else is happening. If you think that someone is overdosing, it's very important to administer naloxone. There's 3 ways that it is available. The first one is the Narcan nasal spray. This is FDA approved for naloxone overdose. The second that is available is the Evzio auto injector. It has visual and voice instructions, making it easy to use for someone and keeping them calm in a situation of overdose. And the last is the overdose emergency kits. So it comes with an adapter, a nasal adapter. If anyone does have other questions about how to obtain or questions about how to use, I have trainers on all of these things that you can see me after, and we could talk about how you can obtain naloxone. There's sheets down here that you could take to your pharmacy or take to Medicap pharmacy to obtain your naloxone.
Next speaker, I have a warm spot in my heart for the Pennsylvania State Police. I sort of cringe when I see the uniform because my dad was a sergeant in the State Police for 30 years. So with that, I thank Kevin Smith to talk about enforcing the epidemic.
I'm Sergeant Kevin Smith. I'm with the State Police now 20 years. Took career path, all sorts of different types of aspects. As of May, I came back to Bethlehem and I was put in charge of the Community Services Office. And these are the three aspects, I think, of combating any drug problem. Most people would see the second one there, enforcement, and find that's the state police's role in it. We go out, we arrest drug dealers, we put them behind bars and that. But we need to take a greater role, and I think we're attempting to do that locally as well as statewide, as both the treatment and the educational aspect of it. How do we inform the public? Forums like this are important. But even so, I think we need to get more into controlling the airways, such as kids are all into social media. We need to get the Facebook pages out there. We need to get the advertisement out there in the forums that they respond to. You know, if we're coming here, and I don't see any or maybe there's a couple younger teenagers here, but we need to get those at risk, and how do we target them? I recently had one of my CSOs, we're going to try and work with L-Tri-C to develop some programs that the students will develop the programs and we'll be part of the educational aspect. The idea there is find out how they learn, what they grasp, and therefore we adapt to them instead of trying to make them adapt to the models that we've had all these times, you know, like you'll come to us. So if we learn how to go to them and teach them the way that they learn, maybe they'll receive the message a little bit better. So that's our goal in that. The last aspect of discussion for me is the enforcement aspect of it. We can put drug dealers away, we can do undercover buys, we can, you know, put drug users away, but the elements of heroin addiction goes further than that. My friend was a victim of his son regularly stealing from him, and he'd come to me about what to do. And from a law enforcement perspective, my advice was always have him arrested, get him in the system. Probation will then, you know, possibly for drug tests and everything else. But all that advice I gave him in the end, his son ended up in the same place as someone who maybe was never in the system. So I don't think there is an easy answer. I don't think you could take a hard line and say this is the only way to go. You as an individual probably need to try to feel that process out yourself and maybe use support groups and others that have been through it to help you know what to expect and the pitfalls of each are. But you know, that's something I think is a personal decision of having your child arrested for stealing from you. But we are looking into limiting their resources for selling stolen goods, like pawn shops, stuff like that. We monitor Craigslist and all the other selling avenues. You as a parent, you know, or part of the community need to look for, you know, you have a kid with no job, comes into your house, all of a sudden he's got a new PlayStation or something like that, is where are they getting these items from? You know, they're trying to turn that into money so that they can support their drug habit. So probably the best thing you do is to have a constant vigilant attention on your kids if you think they're at risk, and look for things that are just out of place. Look for things that just maybe don't make sense to you. Your hair stands up and says, that's not right. And if you think that, there's probably more to it, and look further into it. I would suggest, you know, as much as possible, which I understand this is an impossible task, is try to know your kids' passwords and all important, knowing their password to get into their cell phone. One of the struggles my friend went through was when his son passed, you know, like his cell phone was useless at that point because it had a password protected on it. He couldn't get into it, and he was really starving for information. I'm sure these kids aren't going to share it with you. My kids, I had to threaten with cutting their phones off in order for me to have access to their phones, and that worked eventually. But so that's, you know, take those steps. Try to track cars that are coming to and from your house, friends, associates. I'm of the opinion someone who's doing something like this, their friend group is going to change regularly because the same people will not always be around and available for drugs. So they're going to wear out their welcome with one group and then switch to another group and another group and another group because they're just looking to use everybody to get their next high. So be ready for the friend switch. And anytime a new friend comes, just write the license plate down. You know, do that and just copy down, keep a list, you know, friends' names and stuff like that. So if something ever tragically happens, at least we have somewhere to start. And I say that and I get into the drug delivery resulting in death. And this is somewhat of a hot topic because almost every house we go to where there's an overdose, we have a parent who wants us to arrest the dealer. And I really wish it was that simple. I mean, if it was that simple, we would. But that's a very hard section to prosecute. What we know in our heads to be true or what we think to be true is not what we can prove in a court of law. Essentially, I'll paraphrase what that says up there into common sense language from my perspective, in my opinion only, so you can't take this to court, but is the individual pretty much has to know they're giving you a drug that's going to kill you. Just dealing heroin to someone is not going to meet that standard. They're going to have to say, yes, I know I gave them heroin laced with fentanyl, and I know that could result in death, and I did it anyway. And essentially, without that statement from them, it becomes a monumental task for us to make that arrest. We just recently made one of those down in Bucks County. 2 different people were delivered the same batch of heroin by the same person, and the person said that they knew it was laced with something, and it resulted in death of those 2 people. We were able to make that whole connection. But just someone deals heroin to someone and they die as a result of it, unless they come into our office and say, well, yeah, he told me he was going to intentionally overdose to kill himself, that section is relatively not going to apply. So in my friend's instance, like, he was hurt by that. He wanted something to be done. He wanted us to go after the dealers, and we did. We tried to get intelligence, but it never led to the level where we could make the arrest. I appreciate your time. Thank you.
Our next speaker is an orthopedic surgeon. He was the captain of the swim team here at Parkland High School. He's the team physician now of Parkland High School, Lafayette College. During his fellowship, he was an assistant physician, team physician for the Los Angeles Lakers. I'm going to introduce Dr. Nick Slenker, who's going to talk about the increasing opioid role in sports medicine.
All right. So I'd also like to just say a thanks to Dr. Tom Meade for putting this on today, because I think it's such an important topic for us to be together talking about now. My specialty is in sports medicine. Currently a team physician here at Parkland as well as Lafayette College. And then I've had the good fortune to be an assistant physician previously in Los Angeles, working with the Lakers, Dodgers, and Kings, among some other teams. Playing with injuries and playing through pain is nothing new in sports today, but really athletics in our society has taken on a whole new life. We live in an era where our professional athletes are literally signing contracts, worth hundreds of millions of dollars. So it really seems that, the pressure to succeed is at an all-time high for these athletes. And we see that, in professional players all the way down to our biddy leagues, Pop Warner, T-ball. It seems like pressure in sports today is really ramped up. We've really seen a dramatic increase in the abuse of narcotic painkillers in athletes, used to, again, stay out on the field and stay competitive. And nowhere have we seen this more as far as an epidemic than in our National Football League. And it's been in the press recently. There's been 2 huge lawsuits that have been brought against the NFL by former players, alleging, among other things, that the overuse of narcotics in the locker rooms has significantly contributed to the problems of concussion, traumatic encephalopathy, depression, addiction, among the other devastating medical problems that some of these guys have when their careers are done. In the largest study to date at Washington University in St. Louis, they looked at a cohort of ex-NFL players. So they spoke with 644 ex-NFL players about their use of opioids, both during their playing time as well as afterwards. And what they found was that NFL players were misusing prescription narcotics at a rate 4 times that we see in the general population. This study also highlighted how many of our athletes are getting the prescription painkillers from non-medical sources, with 63% of them saying that they obtained their prescription narcotics from a non-medical source, be it teammate, coach, trainer, family member, dealer, the internet, you name it. I mean, these guys have access to it. And this is a quote from Kyle Turley. He's an ex-offensive lineman in the NFL, and he's actually, he's one of the players involved in the lawsuit against the NFL. Really just describing how prevalent prescription painkillers are in the locker room. And I can tell you they're everywhere there. These guys have access to it. And so much so that, a lot of the players are savvy. They understand that it's not healthy for them. And so a lot of these players today, and you hear about it in the press, are turning towards medical marijuana, or what they consider medical marijuana, as a safer alternative to chewing Vicodin, chewing Percocet before the games. And quite honestly, it is probably better for their long-term health. And really, when you talk to the guys, stories abound as where in days gone past, on the plane ride home, the trainer would just be walking down the center aisle, and the guys would just be holding up a number, and that's how many Percocet or Vicodin they wanted. Or there's NFL doctors previously gotten in trouble writing prescriptions, just huge prescriptions for Percocet or Vicodin, and with the only patient name is just listed to the team. So these practices, there's been a lot more scrutiny on this, so these practices are not as prevalent, but still, like I said, the guys have access to it. There's trainers, there's people around the locker room who can get this, even if they're not getting it from their physician. So while it's clearly easier for the professional athletes to get their hands on this, this is also a serious problem with our younger athletes. And in athletics, with the arduous demands of competition, put these athletes at a higher risk of acute pain. Then they look for painkiller, and just as was described up here, it's a knee-jerk reaction. Lots of pain, give them a narcotic. In the most recent NCAA survey, they looked at, they asked athletes over the previous year. They see 23% of those athletes received an opioid prescription, and 6% admitted to using without a prescription. And in high school, we really see the same thing. Several national studies have shown us that high school athletes have a greater risk of being given a script for narcotics. They have a greater risk of misuse of those narcotics, and they have a greater chance of diverting, so giving away to their friends. And the studies have also shown us that the high impact sports or high injury sports such as wrestling, football, they're at the highest risk for this, obviously because they have the highest severe injury rate. The problem that we see today is probably more of a medical problem than a recreational use problem. And we see high schoolers who are given an opioid prescription in a medical setting, 33% more likely to misuse after graduation. And in this quote by, this is the medical director at the Phoenix House. He says the issue with young athletes is medical use, not non-medical use. Young athletes are becoming addicted to opioids through medical treatments for injuries. And playing sports actually increases the risk of addiction if injuries are treated with opioids. So, in conclusion, looking at this, I think, first and foremost, as those of us who take care of these athletes as physicians, we have to do a better job. We have to be vigilant in our prescribing practices, looking to the alternative medications, the alternative ways to treat pain, which are, in a lot of cases, every bit, if not more effective than the opioids that we've been using for decades. It's important to look, for the warning signs, be vigilant, looking for depression, looking for an athlete who's continuing to use longer than we think that they should. But it's also really important, I think, that we address the culture surrounding sports. And that really starts with, parents, coaches, friends, teachers, everybody around the athlete. Because, ultimately it's going to be the athlete who makes that decision to take a painkiller, and oftentimes they know it's not a smart decision. So it's imperative that we let them know, how risky it really is, how much of a problem it can really be. But in addition to this, it's also really important that we let them know that this decision is, it's a lot different. In a professional athlete, who's in a contract year, who's, he has millions of dollars on the line. Some of those guys are willing to take those risks, but when you see a high school athlete, trying to stay on the field and willing to take painkillers just to play through the pain, and they're not getting paid to play. It's it just makes no sense whatsoever. So I think as those of us around the athletes, it's really important that we do a good job of recognizing that. So thank you very much for having me today.